Okay, guys, we are going to do chapter 18, neurological emergencies. Um, let's go ahead and get started. There we go. So we're going to talk about neurological stuff, anatomy, presentation, and management of decreased levels of responsiveness. We're going to discuss seizures and strokes. For some reason, my clicker is not working. There we go. The anatomy, physiology, pathophysiology, assessment and management of stroke, transient ischemic stroke. So we're going to learn what that ischemic is. Seizures, status epileptics, and headaches. So stroke is the fifth leading cause of death and leading cause of adult disability in the United States. It's common in geriatric patients. Contributing factors for stroke include family history and race. New treatments are available. Seizures and altered mental status may also occur. Seizures may occur as a result of recent or prior head injuries, brain tumors, metabolic chain problems, fever, uh, generic disposition. Possible causes of altered mental status are going to be like intoxication, head injury, hypoxia, stroke, metabolic disturbances. Treatments vary widely. This is why, and you guys have heard me say it, assessments are so important. Um, because we've got to work through all this and figure out what's going on and what the possible cause is so we can treat it appropriately. Let's see. The brain is the body's computer. We all know that. Controls breathing, speech, and all body functions. Three major parts is the brain stem, the cerebellum, and the cerebrum. The cerebrum is the largest part of the brain. Just a little picture there. Cerebrum is your main brain, if you will. That cerebellum is in the back bottom portion. You've got your spinal cord, your skull. Um, Brainstem controls the most basic function, so breathing, blood pressure, swallowing, pupil constriction. The cerebellum controls cerebrum. Cerebellum, sorry, controls muscle and body coordination. Uh, the cerebrum, it's divided into your right and left hemisphere, so right brain, left brain. Each controls activities on the opposite side of the body. The front of the cerebellum controls emotions and thoughts. The middle controls sensation and movement, and the back processes sight. Some people find this kind of difficult. If we have a um, left-sided facial droop, left-sided weakness, then it is a right-sided stroke. If we have right-sided paralysis or weakness, then it is a left-sided stroke because for some reason our brain controls the opposite direction. Kind of weird. In most people, speech is controlled on the left side of the brain, near the middle of the cerebrum. Messages sent to and from the brain travel through nerves. 12 cranial nerves run directly from the brain to parts of the head. The rest of the nerves join the spinal cord and exit the brain through large openings in the base of the skull called the foramen magnum. That's that big hole at the base of a skull. Um, the way I describe it in my class, where I'm from, hunting's a big thing. It's where you hang your deer skull up on a nail. If you just do the skull itself, it's just that big opening at the base of the skull. At each vertebrae, the neck and back, two nerve branches out, spinal nerves. These carry signals to the body. We've all seen those diagrams of all the nerve endings coming off of your um, spine. That's what we're talking about there. There you go. Um, so your brain stem, foramen magnum's going to come. So right there, that opening, and then it comes down your spinal cord, and you've got these spinal nerves that come off. That is where we get our feelings. That's where we get our sensations. Many different disorders may cause brain dysfunction, may affect the patient's level of consciousness, speech, or voluntary muscle control. The brain is sensitive to change in oxygen, glucose, and temperature. Very sensitive, actually. We have to have a constant flow of oxygen and glucose for the brain to be able to function. And then, of course, temperature, if everybody thinks about it being too high, too low, of course, it'll shut down. But the main one is if we get our temperature too high, we start destroying brain cells as well. One of the most common complaints for headaches, headaches, one of the most common complaints can be a symptom of either another condition or a neurological condition on its own. Only a small percentage of headaches are caused by a serious medical condition. Tension headaches, migraines, and sinus headaches are the most common. So a tension headache caused by muscle contraction in the head and neck attributes to stress. Pain is usually described as a squeezing, dull, or as an ache. Usually do not require medication or medical attention. These are the ones you take some Tylenol or Advil, and sometimes it'll go away. A good neck massage can fix this. We've all had some sort of stress headache, and that's what this is. Migraine headaches are thought to be caused by changes in blood vessel sizes in the base of the brain. Pain is usually described as pounding, throbbing, or pulsating, often associated with nausea and vomiting, and may be preceded by visual changes. Can last for several hours or days. Migraines, bright lights will affect these, loud noises. These are the ones that you curl up in a dark room in bed and just cry because they hurt so bad. And they can last quite a while. Sinus headaches, these caused by pressure, that's a result of fluid accumulation in the sinus cavities. Patient may also have cold-like symptoms of nasal congestion, cough, and fever. Pre-hospital emergency care is not required for this. Serious conditions that include headache as a symptom are hemorrhagic strokes, brain tremors, and meningitis. Don't just rule out a headache as not being important. We still have to do our full assessment. We still have to get our history and try to build that puzzle and find out what's going on. Don't just rule out a headache as nothing. And if they want transported, we transport them. We treat what we can find. We treat our patients and our vitals and our signs and symptoms. So strokes, a little bit different ballgame, also called a cerebral vascular accident or a CVA. Interruption of blood flow to an area within the brain. And this can happen in two ways, and we're going to talk about that. Results in a loss of brain function. There's two main types. There's that ischemic and there's hemorrhagic. So an ischemic stroke, most common, accounting for 87% of strokes. It's a result from a thrombosis or an embolus. Symptoms may range from nothing at all to complete paralysis. I'm terrible at this word. So atherosclerosis is a blood vessel that's often the cause. So this is buildup of plaque. It's hardening of the artery. Pretty much. Ischemic stroke is when we get a clot that blocks blood flow. So it is a lack of oxygenated blood flow to a part of the brain. That is an ischemic stroke. We're not going to make this any harder than it has to be. So we've got, see if I can, right here, you'll notice there's a clot. Anything past that clot is not getting oxygen, which means that brain tissue, those cells are dying. Everywhere else is still getting oxygenated blood, so we're good. So if we're looking at this, this would be the right side. We use our anatomical positioning. So this would show, if we were to look at the front side of this patient, probably left-sided facial droop, maybe left side of weakness or paralysis in the arms and legs. Because it's the opposite side that it affects. So in ischemic stroke, the best way to remember it is it's a clot in the brain preventing oxygen from getting to certain parts of the brain. Ischemic, lack of oxygenated blood moving where it needs to move. There we go. So hemorrhagic, if we've got our medical terminology down, we know hemo means blood. So hemorrhagic accounts for 13% of strokes resulting from bleeding inside the brain. Cerebral hemorrhages are often fatal. I got to figure out how to get rid of that. Hang on a second. This isn't going to fix it, but there we go. Sorry about that. People at high risk include those experiencing stress or exertion. People at higher risk are those who have very high blood pressure. So just for a minute, let's talk about that. We get stressed or we're exerting ourselves, our blood pressure elevates because our heart's pumping faster and harder. If we have a weak spot in a vessel in the brain, a thinning in an area of that vessel wall, and that blood pressure goes up. If you remember, blood pressure is the amount of force against the vessels, veins, arteries when the heart is pumping. If we have a weak spot and the pressure builds too high, we're going to pop a hole in that vessel. Think of it as a garden hose with a split in it. If the pressure builds too high, it's going to pop a hole, and then we're going to be leaking out through that hole. So that is why high blood pressure, high stress, and exertion can lead to these hemorrhagic strokes. This can also happen through, say, a blunt force trauma, head injury, something like that. I just kind of wanted to point out why blood pressure would cause that hemorrhagic stroke. I think there's a picture coming up where it's going to show, maybe, I'm not positive, kind of there we go. Okay. So this is your aneurysm, hemorrhagic stroke. So your aneurysm is when we get that break in that vessel and blood is leaking out where it shouldn't be. Swelling or enlargement of the wall of the artery results in a defect and weakening in the artery wall. So somewhere in here, there was a split in that artery and blood is now outside of it, which is going to put one, pressure on the brain, and two, it's going to not allow oxygenated blood to get to other parts of the brain because it is leaking out. Transient ischemic attack or a TIA, stroke-like symptoms go away on their own in less than 24 hours, may be a warning sign of a large stroke to come. About 1/3 of patients who have a TIA will experience a stroke. So this transient ischemic attack, this is a stroke. This is a small stroke. A mini stroke is, I think, how most people look at these. Someone has full-on stroke-like symptoms, but within 2 minutes to 24 hours, all symptoms go away. They're back to perfectly normal. This can happen multiple times, but it's usually an indication that a main stroke is coming on at some point. As a full-time advanced EMT, I have ran multiple of these where we get called for a stroke. It's the patient's family says they were altered. They had complete weakness on one side, facial droop, all the signs and symptoms. But then when we get there 4 minutes later after getting the call, they're perfectly normal. Vitals are great. They're answering questions appropriately. Um, if this happens, you should assume they might have had a TIA. Go ahead and try to transport these patients. They're going to not want to go with you because they feel fine now. Um, Here's the deal, though. This is leading up to something bigger. So let's go ahead and educate that patient. You guys have heard me preach about educating patients. Let them know that it's possible that they had a mini stroke or a TIA, and that you feel it's in their best interest to go ahead and be checked out at the hospital. If they don't want to go with you, please urge them to go see their primary as soon as possible. Um, because these things, like I said, they can happen and be gone before you even get to the scene. Um, so be aware of that. So signs and symptoms of a stroke, we've kind of talked about some of them. You're going to have facial droop, sudden weakness or numbness in the face, arm, legs, and one side of the body, decreased or absent movement and sensation on one side of the body, lack of muscle coordination, or loss of balance, sudden vision loss in one eye, blurred or double vision, difficulty swallowing, decreased level of responsiveness, speech disorders, aphasia, slurred speech, sudden or severe headaches, confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, or a coma. Um, I think here in a little bit we're going to talk about how to do stroke scales. So we'll discuss how to test your stroke theory, if that's what you believe is going on. So the left side hemisphere, or left hemisphere of the brain, strokes in the left cerebral hemisphere may cause aphasia, inability to produce or understand speech. Speech problems can vary widely. May also cause paralysis on the right side of the body. So, if you can remember it, we know that right-sided stroke affects the left-sided stroke affects the right side. But if they are having trouble speech wise, it's slurred or they're unable to get words out, then we can start leaning towards maybe this is a left hemisphere. Right hemisphere stroke may cause paralysis to the left side of the body. Usually, patients can understand language and are able to speak. Patient may be obvious to their problem, or sorry, oblivious to their problem. It's called neglect. They don't realize anything's wrong. Um, so a lot of times they don't seek out treatment or they don't respond to their situation like you would expect them to because they don't realize it's going on. Neglect and lack of pain cause many patients to delay seeking help. Patients may have high blood pressure, maybe the cause of the bleeding if it's a hemorrhagic, uh, may be caused by the bleeding as a compensatory response. Increasing blood pressure is an important sign. Significant drops in blood pressure may occur as the patient's condition worsens. Conditions that may mimic a stroke. So this one, we never jump to conclusion and just diagnose something. We work through it. We continue to work through it with our reassessments, and doing our baseline set of vitals and all that. So hypoglycemia, so a low blood sugar, can mimic a stroke, a posticular state, um, subdural or epidural bleeding. Um, these can mimic the signs of a stroke. With that being said, never hesitate to go ahead and call in, report to your receiving facility and say, I think I might have a possible stroke. I'm going to go ahead and call code stroke. That just allows that hospital to get their stroke team ready. But if we're doing our due diligence and we do our vitals and we check that blood sugar, and we treat it appropriately, maybe we'll solve that problem. We get our history, maybe we'll figure something out, but never hesitate to be on the side of caution. Conditions that may mimic stroke. Again, so here we've got the epidermal hematoma. We've got a fracture. So we have a head trauma. You notice that we are bleeding outside the dura, which is that protective layer there, that inside the skull, but outside the brain. And it's putting pressure on the brain right there. Then down here, there's your dura. Okay. There's that protective layer, but the bleed is actually inside the dura, outside the brain itself. Once again, we're putting pressure on that brain. These will mimic a stroke. We are putting pressure on the brain. It is not functioning correctly, and we're going to get signs and symptoms of a possible stroke. Seizures. First off, before we go any further, if you have questions on stroke, they can be confusing. There's a lot that goes with them. Go ahead and send me a message. Let me know if you've got questions or concerns, and we can revisit this. So we'll move on to seizures. It's a neurological episode caused by a surge of electrical activity in the brain. Can take the form of a vascular and or can be associated with a temporary alternation of consciousness. Two basic group is your generalized and your partial. So results from abnormal electrical charge from large areas in the brain. This is your generalized. So if you remember that generalized is a large area of the brain, it's typically characterized with unconsciousness and generalized severe twitching of all muscles lasting several minutes or longer. This is the one that most people think of seizures. This is what they think of. Oh, that was terrible. My coffee got cold. When people think of seizures, unmedical educated people, this is what they think of: the falling to the ground, the twitching, the shaking. This is generalized seizures. It affects a large portion of the brain. Absent seizures do not involve any change in motor activity, characterized by a brief lapse of consciousness in which a patient seems to stare and not respond. This, I don't want to sound insensitive. These are actually kind of neat to see for the first time, because it's like someone's talking to you and they just completely blank out and they just stand there. They are not there. They can be in the middle of a sentence and just stop. The seizure takes place, and then they'll come out of it, and they most of the time they will regain or restart right where they were. What is that? Rango, the cartoon, Johnny Depp's cartoon. The female lizard on there. If you've never seen Rango, it makes no sense, but perfect example of silent seizures. She'll be talking along, and then she just pauses, freezes, and then picks right back up. That is a silent or an absent seizure. Partial focal seizures. So partial focal onset aware seizure, no change in the patient's level of consciousness, may have numbness, weakness, dizziness, visual changes, or unusual smells or taste, may have some twitching or brief paralysis. This is focal. It's going to be smaller area. You remember generalized covered a large area of the brain. This one covers a small area of the brain. Altered mental status results from abnormal discharges from the temporal lobe of the brain, lip smacking, eye blinking, isolated jerking. They will have unpleasant smells, not about them. They will smell something unpleasant. Visual hallucinations, uncontrollable fear, repetitive physical behavior. Okay. Aura. So patients may experience an aura prior to a seizure. can include visual changes or hallucinations. So, actually, I'll keep reading. People with a history of seizures recognize their aura and usually take steps to minimize injuries. Auras do not accompany or occur prior to every seizure, and not all patients with seizure disorders experience an aura. So, people who have had seizures for some time, they're diagnosed, with a seizure history. A lot of times they will see a bright light, or they'll smell something, or they can feel it coming on before it happens, so they will sit down, they will pull their car over, they will go lay down because they know it's coming. um Even if it's someone's very first seizure, it's a good question to ask your patients is, okay, did you smell anything before this happened, or was there did your vision go bad? Was there a bright light? Just ask them if anything was really out of the ordinary right before a seizure happened, because a lot of times they will have that aura. Generalized seizure characterized as sudden loss of consciousness, chaotic muscle movement, and tone and apnea. May exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and or relaxation. Typically lasts less than 5 minutes and is followed by that posticular state. Absent seizures, formerly called petit mal, petit mal, may last for seconds. Patient fully recovers with a brief lapse of memory. Status epileptics, seizure lasts more than 5 minutes, are likely to progress to status epileptics. Seizures that continue every few minutes without a person regaining consciousness or lasting longer than 30 minutes. So the common causes of seizures, uh, there you can look at all these. Trying to look here. So we really want to watch for like head traumas. Um, those are something that we can identify pretty quick and easy. Um, Drug overdoses, withdrawals from alcohol or medications, um, febrile seizures, in children, which will, I think it covers that here in a little bit. If it doesn't, then we'll talk about it. Anyway, epileptic seizures usually can be controlled by medications. So these are some of the medications that we can use for seizure activity. The importance of recognizing seizures. So recognize when a seizure is occurring and whether the episode differs from previous ones. Recognize the posticular state and complications of seizures. Identify other problems associated with seizures. We're going to get into what to do during a seizure here in just a minute. The posticular state after a seizure, the muscles relax and breathing becomes labored, may be characterized by hemoparalysis, most commonly characterized by lethargia and confusion. The patient does not improve. Consider other possible underlying conditions. We never just assume. We continue our assessments and we find every problem. Um, Syncope, seizures are often mistaken for syncope or fainting episodes. Fainting typically occurs while a patient is standing. Seizures may occur in any position. Fainting is not associated with posticular state. So the altered mental status, aside from stroke and seizures, the most common neurological emergency is altered mental status. Patient is not thinking clearly or is incapable of being aroused. In some cases, a patient will be unconscious, and others, the patient may be alert but will be confused. It's important to ask people that are around what is normal for this patient. Are they normally confused? Do they have Alzheimer's? Are they mentally challenged? Just ask friends and family that might be on scene what is normal for that particular patient. Um, Causes of altered mental status: hypoglycemia, hypoxia, intoxication, delirium, drug overdose, unrecognized head trauma. This is where we get our history. This is where we can start working through problems. brain infection, body temperature abnormalities, brain tumor, overdose, or poisonings. So with our scene size up, make an early determination whether it's the cause for medical or trauma. So what possibly causes seizure, or this altered mental status, this syncope episode? Um, was it, were they sitting in their recliner at home, or were they in a car accident? Um, Decide what was going on to begin with. Look for threats to safety. Follow standard precautions. Consider the need for spinal restriction. Call for additional resources early. Look for life-threatening conditions. Perform a rapid exam. Establish priorities of care on assessment of a patient's uh, LOC and ABCs. Investigate the chief complaint. For unresponsive patients, gather any history from family and bystanders, which we talked about. If no one is around, quickly look for explanations for that altered mental status. Try to determine the events leading up to the incident. Obtain a sample history when you can. And what it means by if no one's around, quickly look for an explanation. Study the room. Study the surroundings. Are there pill bottles laying around? Take a look at those. Do a quick count. If they have like that pill counter that some elderly people have, where Monday they have 5 pills in there, Tuesday 5 pills, Wednesday 5 pills. If it's Monday and the pills are gone Monday, Tuesday, Wednesday already, then we can go, oh, okay, so we accidentally took extra pills. It's noticing everything on your scene, and putting a picture together, figuring out what's going on. Vital signs, significant intracranial bleeding leads to a great deal of pressure in the skull, compressing the brain. So you're going to look at like slow pulse and erratic respirations, high blood pressure, changes in pupil size are possible. If the patient has altered mental status, check blood glucose. Check it anyway. Whether they're altered or not, we should be checking on blood glucose on every single patient. Stroke assessment. Okay. So stroke scales evaluate the face, arms, and speech. You can use the Be Fast mnemonic, Cincinnati Pre-Hospital Stroke Scale, Los Angeles Pre-Hospital Stroke Scale, 3-item stroke severity scale, um, Glasgow Coma Scale, which we do on every patient anyway. Me personally, and where I work, we use the Cincinnati Pre-Hospital Stroke Scale. So that Be Fast is balance, eyes, facial droop, arm drift, speech, and time. Did they experience any loss of balance? Is their gait normal? Eyes, is there a change in vision, loss of vision, double vision? Facial droop, does one side of their face droop when they smile? Arm drift. So you're going to have, see if I can adjust my computer. You're going to have that patient put their arms out, palms up, close their eyes. And if anything deviates, then that is a positive sign. That is arm drift. Speech, have them say something. You can't teach an old dog new tricks. And listen for slurring or wrong word. Anything out of the normal. Time, when did the symptoms first appear? This is a big one. When was your last known normal? We want to catch these early, because if it is a clot, if it is a ischemic stroke, we can push that TPA, but we need to catch these strokes as early as possible. Cincinnati Pre-Hospital Stroke Scale. This is the one that I personally use. Have them smile, look at facial droop, do the arm drift test, speech. You can also, just like in like your trauma assessment, reach down, put your hands on their feet, have them push against you. Put your hands under their feet, have them push down, have them squeeze your hands both hands at the same time. Is there weakness on one side and not the other? So Los Angeles Pre-Hospital Stroke Scale. You can look over that. Um, so I'm just going to keep clicking and talk here. So the hospital, when we get to the hospital, they're going to do their own stroke scale. What the point is for us to do this in the field is it gives us the ability to have an idea of what's going on, identify a possible stroke, and call that hospital so they have a heads up. They can prepare their stroke team. That way, the second we roll in the door, things are already rolling. Because if you remember in the beginning, when we started doing this class, I said we always want care to move forward. We never want to move backwards. So if we do a stroke scale on scene, we call in a positive code stroke. When we get to the hospital, we're not going to be repeating things. We go more than likely, we'll be going straight to CT. They're going to do a scan of the brain. Um, so we don't prolong care. That is why it's so important that we recognize and we do these stroke scales in the field, so we can get that patient moving as quickly as possible. All patients with altered mental status should have a Glasgow coma scale done, and score calculated. So eyes, verbal response, motor sensations. So you can have the top score of 15. That's someone that's perfectly healthy. We're doing great. You can have the lowest score you can get is a 3. This sounds bad, but a deceased or dead person has a score of 3. An unconscious person with no response is still a 3. They can still be alive, but they still have 3. So the way we look at eyes, spontaneous, are they following us? Are they tracking us? Are they able to like notice everything? They get 4 points. It's just like your AVPU. In response to sound, do I have to make sound? Do I have to talk to them? Do I have to yell at them to get the responses a 3? Do I have to somehow apply pressure or pain response? That's a 2. And if they're unresponsive, it's a 1. And you can read over these. Your verbal responses, um, do they talk to us? Are they confused? Are they saying words that just make no sense? Are they just moaning or groaning? Um, do they obey commands? Are they able to do what you ask them when you ask them? Um, do do they respond to localized pressure? Do they withdraw from pressure? Abnormal flexion or extension. So do they draw in or are they contorted out? Or none of it. So this is how we score them. So if you have a patient who is tracking you, they're alert, they get a 4. But they're kind of confused a little bit, so that would be a 4. And then let's say that they withdraw from pressure whenever you touch them or whenever you are trying to do your assessment. So that would be a 4. So we're going to have a score of 12. So that's how you do that. You can do it pretty quickly, within seconds. You kind of need to learn this, know it. I know there's a whole lot to learn and memorize here. You can get on like Amazon and buy little EMT cheat cards, like $12 for 15 cards that you carry in your pocket, and one of them is this strokes or is this Glasgow coma scale. So you can flip through them cards and help you. Our reassessment, we want to focus on reassessing ABCs, vital signs, and interventions. As always, compare baseline vitals, make sure that nothing's changing for the worse. Watch carefully for changes in the pulse, blood pressure, respirations, and GCS. Notify receiving facility of patient's chief complaint and assessment findings when we call in that report. A emergency department physician determines if there is a bleed in the brain for the patient with a suspected stroke with a CT scan of the head. If no bleeding is present, the patient may be a candidate for blood clot dissolving medications at TPA. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms. When was the last known normal? This is very broad. Grandma went to bed last night and was fine. At 9 o'clock this morning, she's completely different. She's making no sense. So last known normal was last night when she went to bed. Or family was sitting there talking to the patient and all of a sudden the patient went facial droop and started slurring speech. Okay, last known normal was 15 minutes ago. So it's important that we try to figure that out, because there is a window there when that TPA can be pushed. So we need to know last known normal. Super important. Patients who have a seizure require a definitive evaluation and treatment. Supplemental oxygen is strongly advised. For patients who are having a seizure, protect them from harm, maintain a clear airway by suctioning if needed, provide oxygen as quickly as possible. If the head or neck trauma is suspected, provide spinal immobilization. So I'm also going to contradict myself here a little bit. Okay, I've seen what that one was. Um, if someone's actively seizing, we don't try to hold them down. We don't try to stop the seizure. We protect the patient, protect their head, move objects away from them so they're not hitting them as they seize. I'm really big on get down there with the patient and talk to them while they're seizing. Try to not so much calm them, let them know that you're there. A lot of times seizing patients can still hear you. Get down there, stay calm, talk to them, let them know it's okay. Let them know that you're there. It will be over in a minute. Tell them don't fight it. It will end in a moment. The more we tighten up and we fight a seizure, the more chances are we're going to cause muscular damage or tissue damage. Never put anything in their mouth like you see on TV. We don't do that. Just protect that head, protect that spine, make sure that airway's open. It is not uncommon for someone in a seizure not to be breathing. So as soon as the seizure's over, we need to make sure that that airway's open, that they're breathing. If they do vomit or they're full of secretions, we need to suction that out. We can lay them in that recovery position if we want to or need to, lay them on their side. Just most important thing is stay calm and talk to these patients, stay with them, be empathetic. So for patients who continue to have seizures, as in status epilepticus, suction the airways needed, provide positive pressure ventilations, transport quickly to the hospital or rendezvous with ALS if possible. You should be concerned if the patient complains of a sudden onset of severe headache. If sudden headache with fever, seizures, altered mental status, or following trauma, this is an indication that we have something going on in our head. We need to go ahead and consider this a life threat. Always assess the patient for other signs and symptoms that might indicate more serious conditions. Apply high flow oxygen. If tolerated, provide a darkened, quiet environment. Do not use lights and sirens during transport. This can actually make it worse. Sorry, we was talking about migraines. Kind of jumped the gun there. Remember that dark, quiet. We want to curl up in a corner and cry. So we need to make sure they're comfortable. Give them oxygen. Keep it dark. No lights and sirens. Even if you can, hang a blanket across that back window and block the light from coming in that way too. Emergency care for stroke, support your ABCs and provide rapid transport to the stroke center or most appropriate hospital. Maintain SpO2 levels of 94% or above. Oxygen therapy not recommended unless the patient is in respiratory distress or hypoxic. So let's watch that SpO2. If possible, transport to his designated stroke center. Sorry. Seizure care. The patient may be post-icular state upon your arrival. The patient may still be having a seizure. Can go either way. Continue to assess ABCs, protect the patient from harm. Let's go ahead and get as much information as we can from whoever's available. If the patient refuses transport after seizure, contact medical control. Follow local protocols. Educate, educate, educate. Talk to your patient, talk to the patient's family. Sometimes they tell us no 10 times, but if family's on scene, sometimes the family can convince them to go ahead and go to the hospital. That's why having knowledge and being able to educate patient and family is so important. Altered mental status. Remember, this comes in so many different ways. So many things cause altered mental status. So determine the cause. Provide spinal motion restriction if it's indicated. Provide airway and ventilation support. Transport to the appropriate facility. Okay, a 41-year-old man presents with slow, irregular breathing, hypotension, and dilated pupils. These signs most likely indicate functions of the. You can pause these and answer them. I'm going to move through pretty quick. A, it's the brain stem. It's responsible for functions such as breathing, blood pressure, and or pupil constrictions. An acute ischemic stroke is caused by. D, two types of strokes: hemorrhagic, which is a bleed; ischemic, which is that blockage, not allowing oxygenated blood to get to the brain. A 56-year-old man experiences a sudden severe headache and then becomes unresponsive. He has a history of high blood pressure. The most likely cause for his condition is a hemorrhagic stroke. Sudden onset, um, and unresponsive, severe headache. Unlike an ischemic stroke, a transit ischemic attack, or TIA, is characterized by all of the following except. Yep. B. These things will resolve within 24 hours. Usually it's within minutes, but it can hold for 24 hours. And then it kind of takes care of itself. Patient with suspected stroke presents with slurred speech that is difficult for you to understand. This is referred to as. This is kind of a tricky question. D, it's yeah, I can't even say it. It's defined as slurred, poorly articulated speech. A type of seizure that is characterized by severe twitching of the body of all the body muscles and lasts for several minutes or longer is called. This is what everybody thinks of when they think of a seizure. It's gonna be D, not G. Generalized seizure. Covers a large area of the brain. It's what most people think about when they think about a seizure. Generalized, if you'll remember it that way. The most important reason for promptly transporting a stroke patient to the hospital is. B, those clot busters can reverse the strokes. They can dissolve the clot. That's why last known normal is so important. Which of the following are components in the Cincinnati pre-hospital stroke scale? C, facial, speech, and arm drift. This is where we look for facial droop. We have them say a sentence, and then we do that arm drift. Excuse me. Your patient opens his eyes when you say his name, is making incomprehensible sounds, and withdraws when you pinch his elbow. What is his GCS score? So remember, we kind of did one of these. So opens his eyes when you say his name. So that's going to be verbal response. He's making incomprehensible sounds, any withdrawals. So pause this, go look up the GCS scores, little drawing or whatever. Get in your book and look and figure that score up. So a score of 9. If a patient claims a severe migraine, how should they be transported? Yeah, without lights and sirens. Remember, we want to keep it dark. We want to keep it quiet. All right, guys, you survived that one. Thanks for sticking it out with me. And I guess I'll see you on the next one.